Right. So as Katie has introduced me, I'm Okwemi Adetokunbo. I'm actually Director of Finance at the NHS South East London ICB, and I'll be presenting on Journey to an Integrated Care System. Right. So do you want me to share my screen? I've got two screens, so if you see me looking there up and down, that's what's going on. Shall I share my screen, or do you still have the copies? What do you want, Becky, Katie?
I'm happy to share. Have you sent in a copy of your slides?
Yeah, I have. But if you struggle to find it, I've got it in front of me. I can just share it quickly.
I've got them right here.
Okay, brilliant.
Oh no, I haven't. They're the same ones that we've just seen. I haven't got them. Sorry.
Okay, I'm happy to share quickly, just so that we can have more time to for questions and to discuss. Save time on there. Right. So there you are. So we're looking at Journey to an Integrated System. We'll be looking at first, how did we get to where we are? And I'll start with the previous legislative reforms that have occurred to the NHS since it was established in 1948. Right. So we had a structure before that time, before April 2023, and that structure, just to get familiar with the keys, we have the green dotted lines showing you accountability and licensing. The red lines are showing you the funding and commissioning responsibility. So pre-April 2013, you had the UK Parliament. The UK Parliament licensing and funding the Department of Health. The Department of Health, then we had what we call the Strategic Health Authorities, SHA. At that time, we had 10 of them in 4 clusters by that March 2013, such that those were licensed and were accountable to the Department of Health, and also funded. With that red line, you will see that. And then the Department of Health then funded and commissioned Monitor. We had Monitor at that time, and the Care Quality Commission, which we call the CQC. Monitor regulated what you would later learn as the Foundation Trust, and the Care Quality Commission were responsible for licensing and inspection. Then if you go down, you see you have the Primary Care Trust. Primary Care Trusts were licensed by the Strategic Health Authority at that time and funded by them. You had 151 primary care trusts in 50 clusters by that March 2013. And the Primary Care Trust in turn funded the NHS Trust, 100 of them at that time, and NHS Foundation Trust, 145 of them. And then we had other providers within the system, private, voluntary, and other non-NHS providers, minimal of them at that time, such that the Primary Care Trust also had primary care services commissioned, licensed, and funded. For example, the GPs, the dentists, and opticians, pharmacists. Now, in 2012, there was a legislation called the Health and Social Care Act, and it introduced the most extensive and controversial reform to the structure of NHS since the service was established in 1948. Now, that care, the part 3 of that care in 2014 also established what we call the Health Education England and the Health Research Authority as statutory non-departmental bodies at that time. That reform was deemed extensive and came into effect 1st of April 2013. So many of those provisions came into effect 1st of April 2013. And what did it do? It's legally allowed NHS England and Clinical Commissioning Group to take on statutory responsibility for commissioning and health service, such that the structure I've just explained to you became abolished. You now had what we call UK Parliament, the Department of Health. You now had NHS England replacing what is the Strategic Health Authority. And then the DH also funded some public health services then through local authorities. That's the first time we're seeing that change. And you had the Monitor still licensing and making economic regulation, and the clinical care, the Care Quality Commission, which were accountable and licensed by the UK Parliament direct. But the funding flowed from the Department of Health. So with this Act of 2012, the CCG were born. You had local authority and new public health responsibility. So local health watch organization came into being. It abolished the strategic health authority and the primary care trust. What the CCG did then, what they did then was they assessed the needs of the local population and decided on their health needs. They bought as many services as money could afford at that time. But then notably that time, the Health and Social Care Act of 2012 created what we call a market of competition, such that you had private sectors that could bid for NHS public funded services, and it was thought that it had negative impact on quality. And so many of the things were done at the expense of quality. So it created that competitive market. And because of that, I move on to this next slide. It was thought that despite this major reform of that 2012, NHS continued to face rising demands and costs, widening gap in health of the population and quality of care. In fact, it was projected that the funding gap threatened the stability and sustainability of NHS. It was that bad. And it became considered to be unprecedented. So according to the Institute of Fiscal Studies, health spend between 2009 and 2010 and 2014 and 2015 rose by 1.1% on average per year, while cost pressure of the services are estimated to increase by around 4% each year. So it wasn't matching at all. And to close this gap, NHS decided they'd come up with what they call the 5-year forward view. It was published in October 2014. The ambition was for greater partnership. It proposed new ways and a collective vision for how health services needed to change between 2015-16 and 2020-21. And it was a move towards collaboration rather than competition. Like I said, the Health and Social Care Act of 2012 was more about competition. You bidded for services and quality was jettisoned. And what needed to be reported to monitor at that time were variations. But now we're talking about collaboration rather than competition. The three key drivers for this change across NHS were identified. It was health and well-being, care and quality, funding and efficiency. Now, 16th of December 2015, the Sustainability and Transformation Fund, STP, of 2.1 billion was announced, and it was to support 1.8 of it would provide help to challenging hospitals, because by this time, many NHS trusts and foundation trusts were in major deficits. And so 1.8 was going to go towards that. And then the remaining balance was going to go towards these organizations, focusing on changing the way they provide health quality care for patients. Now, the central components of the 5-year forward view is accelerating integration of care, of health and social care services, and introduction of new care models. NHS organization they were asked to come together. They were asked to come together by geographic footprints, and that gave birth to what we call Sustainability and Transformation Partnership, STPs, and they evolved from place-based approaches to health. So it's geography, it's where you are, who you can collaborate with where you are at that point. So by end of January 2016, local NHS services and local authorities had formed 44 separate STP footprints, and it was made up of NHS organization, clinical commissioning groups, NHS Trust, NHS Foundation Trust, including mental health and community services and primary care services, as well as local authority, along with other health and care services within a defined area. So that's geography there now. Now, they were required to incorporate better integration with local authority services, including but not limited to social care and public health. Now, at this point, there was no change to the underlying legislation governing how organization within the health system operates. So it meant that was considered to be a barrier in collaboration, because what they then did was more of moral suasion. So a reform to the NHS internal market was necessary on the legislative part so that these SCPs could be empowered. I move on now quickly. And this gave birth to the emergence of what we now call the integrated care systems. Now, ICS existed in one form or the other, like I explained, since 2016. They emanated from the well-established SCPs. If you remember how the SCPs came into being by geography, go and collaborate with health providers and local authorities around you. So that now began to develop into what we now have as the ICS. Now, they took lead in planning and commissioning care for their population and providing system leadership. The plan was for all SCP areas to eventually become ICS, but there was this legal barrier of the Act, Health and Social Care Act of 2012. It was an hindrance because if you're not legally enabled to do something, everything you do was not binding. It was about if you wanted to do it. NHS England now went on to produce a 10-year plan to improve access, care, and outcome for patients. This resulted in what we call NHS LTP, and it included actions for workforce, technology, innovation, and efficiency. Significantly, it proposed the legislative changes to the system structure of the NHS, bringing together different NHS organizations and local council into the ICS. Now, ICS seen as central to delivering that NHS LTP long-term plan. In 2022, the much-needed framework was birthed, now called the Health and Care Act of 2022. It received the royal assent in April 2022. This is the biggest reform in decades because it's enabled the integrated care system. Now we have 42 ICS across England. It covers population of around 500,000 to 3 million people. Collaboration and coordination of local services now require change behavior. It now requires the changes to our behavior and attitude across the system. Now, let's zero it down to our experience in NHS Southeast London. When we were the STP footprint, we were our healthier Southeast London house health, and it's one of the capitals, London's biggest, one of the capital's biggest and first STP is the formation of 6 CCGs and local authorities, 5 provider trusts, and numerous voluntary sector partners. By April 2022, NHS Southeast London moved into a form of ICS. We merged those 6 CCGs together to name them, as you see on my screen. We have Lambeth, Suffolk, Lewisham, Greenwich, Bexley, Bromley. And we became an integrated care system across health and social care services. By 1st of July 2022, with 1.9 million population, now we've exceeded that, over 2 million now, but at that time, 1.9 million population, we were established as a statutory body to support and build upon our existing health and care partnership established by the existing integrated care system, our healthier Southeast London. Now, moving on. Now that you've now seen how the integrated care system is birthed, let's see what the structure now look like. It is the key planning and partnership for the healthcare now from July 2022. You have the NHS England. It manages and supports NHS bodies working with and through the ICS, and you have the clinical care, the Care Quality Commission, which does independent reviews and rates the ICS system. What are the statutory ICS system bodies? We have the Integrated Care Board and Integrated Care Partnership. Members of Integrated Care Board are listed there: chairman, non-executive directors, members selected from nominations made by NHS Trust, Foundations Trust, local authorities, GPs, and individuals with expertise and knowledge of mental illness. And our role as an integrated care board is to allocate NHS budget and commission services, produce the 5-year system plan for the health system. And then we have the cross-body membership and influence and alignment with our integrated care partnership. Membership of that are representative from local authorities, the ICB, that's why you see those 2 arrows going in there, the Health Watch, and other partners. The role is to planning to meet the wider health, public health and social care needs, develop and lead integrated care strategy, but does not commission service, unlike the ICB. There is this influence. So what do we influence? If you see my table, the lower table here are partnership and delivery structures. You see we have what we call the provider collaborative there. We have the health and well-being boards. We have the place-based partnership, and we have the primary care network. What is our own purpose, our own key aims within the ICS? We've got to improve outcomes in population health and healthcare, enhance productivity and value for money, support broader social and economic development, and tackle health inequalities in outcomes, experience, and access. Now, let's look at what our integrated care board look like. Our main role is to deliver the integrated care strategy, develop a plan for meeting the health needs for the population, directly accountable to NHS England for NHS spend and performance within the system, arrange for the provision of health service in our geographical area. What are our members? For South East London, the chairman, chief exec, 3 non-executive director, executive director of planning, chief of staff, chief finance officer, chief nursing officer, and we have 2 joint medical director, director of communication and engagement. We have chief people officer there, place executive directors of our 6 places, and then we have partner membership with primary care, mental health, community, acute care, and local government. This is very different from what you used to have under the 2012 Act. You can see this is an integration of many representation across the board. Department of Health and Social Care funds NHS England, like we've said, in 2023, the spend was 155.1 billion. This is 3.6% average growth in real terms per year, compared to during the old act that was 1%. And then you will see other things there. Our 6 priorities, NHS South East London, our 6 priorities are in there for you to read, and all that statutory obligations we must perform. Just to move on quickly, because some of them are also crossed across. Now, what is our system? Yes.
Sorry to interrupt. I don't know if you're able to just switch to full slideshow view, just to make the slides slightly bigger for people.
I can do that. On current slideshow.
Perfect. Thank you.
Yeah, 1 minute, because I can't see it. Okay, yeah. All right, that's fine. Yeah, thanks for that. Okay, so what is our system architecture and partnership? We have the integrated care partnership, like I explained, also in the ICS. Then we have the integrated care board. We have the local care partnership. We've not touched on that. And what do? They lead the integration and innovation in community-based services in borough place. So in this new structure now, you have what we call the borough place and neighborhoods, which aim to build community as well as join-up care. Now, provider collaborative, they are a group of providers leading improvement of specific services. So you have things like acute provider collaborative, mental health, and community. You will see more details of that as I go on. Then you have what we call the primary care network, which is GP practices working together with community, mental health, social care, pharmacy, hospital, the voluntary community, and social enterprise services in local area. Right now, our integrated care partnerships is a statutory joint committee of the ICB. I told you the difference between this is that they don't commission services, but they have great influence as well. And then the local authorities in ICS, they bring together a broad set of system partners to support partnership working and develop an integrated care strategy to address our wider healthcare, public health, and social care needs of the population. Now, NHS, our own South East London ICP sets strategic direction, provides leadership and support of key South East London wide programs and all system partners to account for delivering of the priorities in our ICS strategy. Members of our partnership include 6 local authorities, because as you remember, the geography of the South East London patch includes those 6 local authorities. The chair of our best provider organization, when we go on, you see our provider organization, director of public health, adult social care, and children's services, a representative from the King's Health Partners, primary care and voluntary community, and social enterprise sector, and Health Watch. See the diagram below gives you a better understanding of our integrated care partnership structure. Move on. Now, our provider collaborative, like I mentioned, there are partnership arrangements involving at least 2 NHS organizations, NHS trusts, working at scale across multiple places. We have a shared purpose and combined decision-making arrangement, and it's aimed at transforming health services by promoting better health outcome and values. So if I go on to what we have on our provider collaborative, we have the Southeast London Acute Provider Collaborative. This is, we call it APC for short. It includes King's College Hospital NHS Foundation Trust, Guy's and St. Thomas NHS Foundation Trust, and Lewisham and Greenwich NHS Trust. They work together to improve the way acute care, which refers to short-term treatment, is delivered within Southeast London. They are core components of our collaborative work in elective care as well, and diagnosis and recovery. So the APC reports into committee in common of the 3 trust board and to the ICS leadership group, recognizing that the collaborative is a key part of the wider Southeast London integrated care system. Excuse me. We now have what we call the South London Partnership Mental Health Services Collaborative, SLP. And as expected, you will find our mental health providers in here: Oxley's NHS Foundation Trust, South London and Mosley NHS Foundation Trust, called SLAM for short. We have Southwest London and St. George's Foundation Trust. So they collectively deliver mental health services to a population of more than 3.6 million across Southeast London, and they work across the 2 ICS, because we've cut across 2 ICSs here when you start talking about Southwest London and St. George's here. They've taken their delegated responsibility from NHS England Commission Specialised Services and for CCG funded complex care. Now we now have what we call the Southeast London Community Service Provider Network. Here, this is about community services provider collaboration here. You have Guy's and St. Thomas in here, Bromley Healthcare here, Oxley's and Lewisham. You will see the cross Venn diagram here between acute APC, provider collaborative here, and the CPN, because provider collaborative, our acute trust also provide community services here. And there's another collaboration going on here. And it comprises of all of the Southeast London physical health community providers. It's an informal network rather than a formal collaboration there. They focus on working together there to deliver our strategy. So if I move on now, we have the local care partnership here as well. This local care partnership, they are GP practice working together with community and mental health, social, pharmacy, hospital, voluntary, community, social enterprise services in our local area in groups known as the primary care network. So this then goes into showing the representation in the place. You can see the objective, strategic drive of each of them there. We have the Bexley Wellbeing Partnership, Lewisham Health and Care, One Bromley, Lambeth, Sodok, and Greenwich. You see that this looks like one of those local places coming together as a local care partnership here. So if I move on. Now, we've talked about the structure. I thought it would be good to look at what has been the success of the ICS 1 year plus reflection here. We believe that the integrated care system have made a robust beginning despite the challenging circumstances. The challenges have included things like political and economic uncertainty. There's been inflation, there's cost of living crisis. We've encountered significant financial and workforce obstacles. Particularly, we had a difficult winter last time with immense pressure on our emergency services and backlog in elective care. And additionally, we've had industrial actions. Recently, we still had the junior doctors going on strike. And on top of that, the ICBs have had to reduce their running costs by 30%, despite just being formed months ago. Now, NHS Confederation did a report, a survey from ICS but leaders, and 85% of them responded. ICS, ICB, and ICP response rate at that time. And these are the current achievements that have taken place. So from the responses, most leaders thought that there's been immense building of relationship. The relationships have developed significantly due to local dynamics, local dynamics because it's geographically and place-based of the integrated care system nature and the history and how mature such STP or ICS have been over the years. 90% of the ICS leaders have expressed that ICB and ICP are effectively collaborating, which is good news. Now, ICP, although they don't commission service, but they have the opportunity to expand their roles by involving various system partners, such as places and health and well-being boards, to address the broader factors that influence health, which is very positive. There's more developed system the more developed systems have adopted a productive approach to problem solving. They view challenges as opportunity to talk, to collaborate, to do things together. And according to NHS providers regulatory report, they have the NHS that have shown overwhelming positivity towards the role of ICB in fostering shared responsibility, so that more responsibility is seen among other partners rather than it just being bottled up within the ICB. And there's also the thing about delivering impacts in short and long term. So they believe that the impact has been made in various areas over the past years, such as in strategic planning across the system, managing winter's pressure, strengthening collaboration, supporting primary care, and ensuring financial sustainability, enhancing engagement, and developing long-term plans. However, it appears as if this is a bit challenging in the period that ICB has been, and there is a view that due to political pressure, we now have a new government though. This could have been momentary actions. So let's see what will happen after the new government is in place. They thought that there should be some area for improvement. There's this issue about devolving decision making, which was hinted first as benefit. So that has not really totally happened yet. In advanced ICS, you have the decision making being devolved to place based. For example, I manage a place, which is Bexley. So there's this yearning for more place-based decision making and delegation of that decision making. And then the harnessing of skills and contribution of system partners. We are seeking ways, the ICS system are seeking ways to maximize the valuable skills and contribution of system partners with positive view of commitment and contribution of system partners. Although there's this thought that there may not be resources down there, but there will be some skills to harness in that area. So if I move on, what are the barriers to integrated working that have been seen so far? We know the workforce. They see the workforce challenge. As at the time of production of this paper, December 2020, we have vacancy in the NHS of 124,000. That's 8.9% of the planned full-time equivalent workforce level. And there is massive vacancy within social care as well, which has risen to 165. The NHS has published what is called the NHS Long-Term Workforce Plan, and it's expected to tackle persistent workforce shortages in the healthcare sector. Although there are concerns highlighted that there remains a lack of comparable plan for social care, because this is NHSE plan to tackle workforce. Nothing has been seen on the part of social care. There's the impact of long-standing underinvestment in social care sector, despite the recent extra funding in 2022 autumn statement. Staff vacancy continues to rise, and low wage associated with lack of opportunity for progression makes it difficult for social care to compete with other sectors for staff, for example, the health sector. And there is the NHS financial position. NHS financial position, I know this is ups, but there are more deficits being reported within the system, and it puts a strain on partnership with local authorities, because when you have to balance your book folks first, makes it difficult to do some things that you would have done innovatively. We've had a situation whereby we pull the plug, pull the brakes on investment and initiative just to balance the books. So that is still ongoing. That's revenue side. On capital spending, there is the capital spending appears to have consistently decreased in real terms over the past decade, and it falls behind other OECD countries. Investing more in areas like upgrading estate and IT equipment can enhance productivity, but ICS leaders emphasize the negative impact that uncertainty and delay in capital funding allocation can have in healthcare system ability to provide high quality care, because sometimes the funding is not even confirmed on time within a financial year, and then it just needs to go to what would not have been the best application of the fund. And of course, then this goes to, if I can just sip a cup of water. Thank you. And then this also goes to the way it affects the transformation of services within primary pharmacy, optometry, and dentistry services as well, because you need funding for that capacity, significant portion of that NHS long-term workforce plan. There's the risk that they have been overloaded in that sector, while also being expected to reduce the running costs. We've talked about the ICB's plan for a 30% reduction, which is affecting the position. So it could be effectively 40% reduction in real terms because it goes into 25, 26. There's the balance of local and national shortage, long-term priorities there. There's a need to achieve the balance in making progress on reducing health inequality. So you have to balance that, how you progress in health inequalities, how you prevent conditions, long-term conditions, and population improvement, and then community focus and delivering short-term urgent and now priorities that normally comes up with political priorities. So let's hope that the new government will favor the NHS in delivering and or removing some of these barriers. I think this brings us to the end of our presentation. I'm happy to take questions.
Hi, Lena, go ahead.
So, thank you. Lots going on there. Hoping me to re-listen to all of it, try and follow. Thank you so much for your time.
I'm sorry, I can't hear Lena properly. Do I need to?
You can't
I'm
hear
on.
properly. Okay.
No, I don't know if anyone.
You're very quiet, Lena.
That's unusual. See, how is that? Any better? No. Hold on. Any better?
Much
Yes,
better.
thank you, Lena. Yeah.
Okay. Yes, sorry. I was just saying thank you. Lots of information there that I think I might need to revisit and try and follow. But I guess just thought I'd kick us off. I have a vested interest in this, partly as a member of King's College Hospital, which is part of South East London ICS. But also in my former role, I worked in Newham as integrated care system manager before the ICSs were statutory. Can you give any examples where patient care has been materially improved as a result of this kind of collaborative working?
All right. Whether I can give an example, okay. Well, I will have to look at data. One thing, if you want something more robust, and I'm glad you're in the system, where patient services have been improved. One thing is that I've heard is about access to care. There's been a lot more access to care within the ICS, the Southeast London ICS, and then also bridging the health inequalities within the ICS, Southeast London ICS. But to be more specific, we could look at data for areas of care and see how that has changed. So if you recall, this is going about 2 years now, not yet, just a year and over since the integrated care system has been in place. There will be need to have some running data to see how things have improved. But within the local care system, what I've heard is there's been improved access, there's been improved communication on how people can actually access service compared to how it was before. But you will need data to support that. Yeah. But you are in King's, Lena. We've worked together as a system to sort our financial problem, which is very notable.
Are you gonna help us with our financial problems?
No, but I'm
not sure the system has it, but we sure as hell do.
Yeah, no, because I'm in finance and I know what the role the integrated system has played in delivering an acceptable plan. We're still in deficit. I know there's still deficit within the system, but the role the system has played, unlike an individual organizations trying to present a plan to NHS for approval. So we've worked together. There've been things shifted across the system, Nina, I can tell you, to accommodate the deficit within one organization. And looking at us as a system, as against when it was under the 2012 Act, where it was that pinpointing that organization is the one with the problem, not us. We have not looked at it like that in the integrated care system. We have looked at it as a system, and we have submitted and worked together to deliver a plan, a financial plan that has been approved by NHS, and we're working to see how we can deliver that together. Yeah, I think that one is notable. Yeah.
We'll look forward to it. Thank you.
I stopped sharing so that we can see faces about that. Could check the chat if there is any question on the chat. Just it's just thanks in the chat. I can't see any question or any hands up.
Anyone else got any questions to ask OPME while we've got her here? It's a great opportunity to get those questions forward. Oh, we've got a hand up. Go ahead.
Hi. I was just thinking about, sometimes when you're in that mix of that real change and that, real transformation, is there anything that you think we should have done that, or on while we evolve, this is where I really like to see and make a difference? Is there something that you think has been missed, or something that you would have liked to have seen as part of that transformation?
Thank you, Michelle. I think one thing that we would like to see more of is the delegation of power to place-based decision-making, to place-based, and it should include total delegation of funding, of budget to place-based, and then making the strategic decision on how care is provided at place-based, because that is still being discussed, and attempts are being made to achieve that as we progress. But I think that would really help, because the place-based are the ones that are closer to the population. Like I explained, the integrated care system is very geographic. So through the local care partnership, through the place-based partnership, the health and well-being boards, so we are closer to the population. I think total delegation should happen at place-based. I think we look forward to that, and then still keeping that collaboration. So it's a kind of a two-way thing. You have strategic delegation of power and decision-making at placement and funding, and then still be able to collaborate together at board level as a system to look at the big picture on how this decision affects the system as a whole. So there is one thing about being able to work in a silo, and at the same time being able to then come out of that and look at it on a broad view on how does this decision actually impact my next borough, my next place, and how does it impact the system as a whole. So it's like we need to have two hearts these days, and the collaboration with the local authority should continue to be intense, continue to be intensified, so that we could have that relationship between health and social care getting more integrated. Thank you for that question, Michelle.
That's great. Thank you.
Any more questions from anybody? No, I think I just want to say from the Proud2bOps team, OPME, thanks so much. That's been a really valuable presentation and discussion. If anybody does have any questions come to mind following the session, please do email through to the team or to OPME, and we'll aim to answer those for you. Becky, is there anything you want to add?
No, just thank you from us as well.
Thank you.
Thank you so much. Bye, everyone.
Thanks, everyone. Bye-bye.
Bye. Bye.